Dear audience, my name is Leila Tigharghar, and let me present you my PhD thesis, The Management of Cervical Insufficiency. I'm a resident doctor at the Department of Obstetrics and Gynecology at Semmelweis University, and my supervisors are Nándor Ács and Petra Merkeli. My SMS is Isabel Amorim, and my statistician is Mikó Bakony. My vision with my project is to make cervical insufficiency an easily manageable disease, and my mission is to find the most effective treatment for it by applying up-to-date scientific results. So I have two ongoing projects at the moment, and let me tell you about it in depth in the upcoming minutes. The first one is investigating the efficacy of different therapeutic modalities for cervical insufficiency on the prevention of preterm birth. It's a systematic review and network meta-analysis. I started this project in September in 2023, and I plan to submit it by this year's May. So cervical insufficiency is the inability of the uterine cervix to retain a pregnancy in the second trimester. It's an asymptomatic dilation of the cervix. Its incidence is quite low in the general obstetric population, but it's much higher in women with a history of mid-trimester pregnancy loss. And risk factors can include conization of the cervix, inflammation, infection, laceration during childbirth, or just the structural weakness of the cervical tissue. Despite having such a low incidence rate, it can have very serious consequences. It can contribute to preterm birth, which already has such a high annual incidence rate, and it can cause midterm pregnancy loss. Treatment is quite simple. It's either pessary, cerclage, or progesterone. They are easily accessible, but there is no conclusive data on which is the most effective. So our aim is to compare the effectiveness to find out which is the best to prevent preterm birth. That leads to a clinical question: which treatment is the most effective at preventing preterm birth in women with cervical insufficiency? We would like to investigate the population of pregnant women with the said condition, also two subgroups, singleton and twin pregnancies, and we would like to compare the three interventions to each other. And the outcome that we would like to measure, the primary one is spontaneous preterm birth before the 37th week or fetal death, and the secondary would be mean gestational age at delivery, length of pregnancy after intervention, and early preterm birth. Our hypothesis is that cerclage, pessary, and progesterone have different efficacies on the prevention of preterm birth. We conducted a systematic search in 4 databases. The search key consisted of the population and intervention domain. We started with over 5,000 articles, and after the duplicate removal, the title abstract selection and full text selection, we had 171 eligible full texts. Among them, we found 41 eligible full text RCTs that we used. So we have one finished preliminary analysis, the preterm birth part, and the rest is still ongoing. So this is just a basic characteristic table. We have 8 interventions, 36 studies, over 11,000 patients in the network. We have 28 pairwise comparisons and 13 with direct data. So this is the network plot. The nodes are interventions, and where there is a line connecting them, that means there is a direct comparison between those interventions. The thickness of the line correlates with the number of studies, and the size of the node correlates with the number of patients receiving those interventions. And this is the heat plot. This is a table of estimates with odd ratios. It helps to compare all the interventions to each other. As you can see, we have 2 statistically significant estimates, meaning that pessary, compared to no intervention and standard of care, is better at preventing preterm birth. Although the other interventions don't have statistical significance, we can still call them clinically relevant. And this is the consistency plot, meaning that the network has good consistency and it can produce reliable results. So the strength of our network method would be that we use only RCTs, and the network has good consistency. Limitation, I would consider that some studies use additional treatments, like additional progesterone next to pessary, and they have different times of application for the interventions, but we prioritized articles that use the interventions in the second trimester only. Our conclusion is that clinicians should consider pessary as a primary treatment for cervical insufficiency, Although less effective, cerclage and progesterone also have benefits. Our implication for research would be that we need further RCTs with more homogeneous population and stricter use of interventions. So this is my progress. I'm currently doing the risk of bias assessment. And let me introduce my second topic, which is investigating cervical insufficiency as a risk factor for developing pelvic organ prolapse. I started this project in October of 2023, and I plan to submit it by this year's September. It is a systematic review and meta-analysis. Pelvic organ prolapse is the descent of the interior wall, vaginal wall, the posterior vaginal wall, or the uterus, or some kind of combination of the three. Symptoms can include discomfort, incontinence, tissue bulging out of the vagina, so you can imagine it can be quite uncomfortable for the patients. Risk factors include obesity, constipation, connective tissue disorder, and mainly vaginal delivery. Its prevalence is very high among women. It's up to 40%, and treatment can be conservative or surgical. Conservative is pelvic floor muscle exercises or pessaries, and still 11% of women undergo surgery for it, and almost a third might need additional surgeries. So our aim is to assess cervical insufficiency as a risk factor for subsequent development of pelvic organ prolapse. Our clinical question is cervical insufficiency a risk factor for developing pelvic organ prolapse? We would like to investigate the population of Paris women who have given birth before, and compare a history of cervical insufficiency to no history of cervical insufficiency. And we would like to measure the outcome of the development of pelvic organ prolapse. We hypothesize that the history of cervical insufficiency is associated with an increased risk of developing pelvic organ prolapse. The implication would be that assessing the risk factors correctly can facilitate early screening and management and help avoid unnecessary future surgeries for the patients. We conducted a preliminary search in 3 databases. The search key consists of population and outcome domain. So here's one of my key articles. It has a very high sample size. It's over 1 million participants. It's a multi-center study with a cross-sectional design fitting our PECO framework perfectly. So we are in the very early stages of this project. The topic is feasible. And to sum it up, I have 2 ongoing projects at the moment. I plan to submit the first by this year's May, and I plan to submit the second one by this year's September. And I would like to thank your attention with a quote from Albert Szent-Györgyi: "Research is seeing what everybody else has seen and thinking what nobody else has thought." Thank you.
Thank you for the time-consuming and also very, very interesting presentation. Both of your topic, especially the first one, is very, very important and clinically relevant, because the protocol was that in twin pregnancies, the first-line therapy is cerclage, and until now. And your recommendation, because the pessary was not recommended in twin pregnancy, but your data is absolutely opposite of what we thought about it. And I ask the audience if there is any question now.
Yes, very interesting first project. I have some questions. I think it's also related to the comment. What would be interested here, the population characteristics, because maybe some patients might need the cerclage, others would benefit the most from the pessaries. So did you also investigate the different population?
We plan to do a separate analysis for singleton and twin pregnancies as well. But yeah, it's still an ongoing analysis, so we will have much more subgroups to analyze.
All right, and are there different pessaries types, for example?
Mainly one that we use in Hungary.
All right.
I have just one question. Are you planning to analyze singleton and twin pregnancies separately?
Yes, as I said, it's a very different population and with different risk factors. So yeah, one of our main goals is to analyze them separately.
Maybe one more question. Is there actually a severity scale about cervical insufficiency? Is there like grade A, B, C, or something like this?
Thank you. No, I'm not familiar with this. I don't think so. It's mainly based on ultrasound diagnosis, and it's pretty straightforward if it's seen, so there is no need to grade it.
Leila, I absolutely agree with Levent. And just a short questions. What do you think, according to your data, where is the place, daily place of our newest techniques, the bilaparoscopic techniques?
We also compared all the interventions. One of the interventions is laparoscopic cerclage, and it seems like that vaginal Tigharghar cerclage has the best effect out of all, so not the laparoscopic one. But we have limited data on these techniques. Most of the articles mention pessaries and progesterones, so cerclage is kind of a limited area.
Yes, but we can perform this in our department.
Just one short comment, because it's a very hot topic in gynecology now, so, and the obstetrics as well. So the laparoscopic cerclage is direct to the patient to a way to the C-section. And there are a lot of other possibilities, like pessary, which is easy to use and easy to take it off at the end of the pregnancy. And the vaginal birth is a possibility after this method. But after the laparoscopic, so the laparoscopic way is suggested for patients who has previous problems, previous miscarriage because of a previous cerclage. So that's the only way when you should use that, I think. But the best method, it's out of question.